start with us on around us, but we're tackling everything, and I think overall we're doing quite well. Thank you for joining us today. We have an outside speaker, and it's really exciting to present to you today Dr. Atul Verma, who is going to be our new Chief of Cardiology at the MUHC starting in April 1st, I believe is the start date. So we're very, very excited to have him present to us today. And eventually will become the Chief of Cardiology at McGill University across McGill. So it's very exciting to introduce you to Dr. Atul Verma. Just a quick reminder to leave your questions at the end, enter your questions in the chat. This session is going to be recorded, and please let us know that you were present at today's rounds by filling out a survey that will be sent to you right after the rounds. So Dr. Verma, who is presenting today, is a cardiac electrophysiologist currently working as the medical director of the Heart Rhythm Program at Southlake Regional Health Centre in Newmarket, Ontario. He trained at the University of Toronto for cardiology and at the Cleveland Clinic for cardiac electrophysiology. He specializes in complex ablation and device implantation. He is an associate professor at the University of Toronto with an interest in clinical trials. He has published over 275 peer-reviewed articles and has an H-index of over 70. And for those of you who missed it when I said it right at the start, he will be joining us as Chief of Cardiology here at the MUHC in April 1st. Atul, thank you so much for joining us today. And the floor is yours.
Thank you so much, Nadia, and I'm really, really looking forward to coming to McGill. It seems like only a very short ways away, and I just bought a house in Montreal, so it's becoming closer and closer every day, so I'm really looking forward to it. I'm going to share my slides with everyone, and I just need confirmation, Nadia, that everyone can see my slides.
We can see your slides, Atul. Perfect. Thank you.
Perfect. So, I know this is general medical rounds, and cardiac electrophysiology is a very specific and a little bit of a weird subset within cardiology. Some of us are considered sort of outsiders from general cardiology, but I'm going to give you just a little flavor today of what has been interesting me in this field in the last little while. These are my relevant disclosures that you need to be aware of. And on the agenda today, it's a little bit of a mixed bag. I'm going to talk a little bit about trials on ablation of persistent atrial fibrillation. I'm going to talk a little bit about whether we can stop oral anticoagulation after successful ablation of atrial fibrillation. And then finally, I'm just going to give you a little sneak peek into some of the new technologies that are around the corner for performing AF ablation. So let's talk a little bit about persistent AF ablation. And for those of you who are not that familiar with AF ablation, we have now for many, many years realized that most of the triggers that are responsible for initiating atrial fibrillation come from around the pulmonary veins in the left atrium. And this is the seminal work by Michel Hasseguer in France, in Bordeaux, where he basically defined where those triggers are. And you can see that most of them are clustered around those four pulmonary veins. And so when we do percutaneous cardiac ablation, what we're doing is we're inserting sheaths into the veins of our patients. We then insert small little catheters into the heart. We perform a transeptal puncture to cross from the right atrium to the left atrium, and then using either burning energy or cooling energy, we basically try to electrically isolate those pulmonary veins from the rest of the left atrium. The idea being that therefore the triggers that originate in those veins can't get into the rest of the atrium, and therefore the patient will not have atrial fibrillation. Now you might be wondering, who are the typical people that we perform AF ablation in? And I think the key factor here is that patients should be symptomatic with their atrial fibrillation. Now, sometimes symptoms can be very difficult to define. Some patients have persistent AF, they feel tired, maybe they have a little bit of left ventricular dysfunction, so they may not be complaining of the classic palpitations or rapid heartbeats that other patients may. But these all fall within the spectrum of symptoms. And generally speaking, we like to get patients while they're still paroxysmal or they are persistent, but with a duration under 5 years. And the reason for this is that once the AFib has become really well established for 10 or 15 years or more, it's very, very difficult for us to terminate it even with our ablation procedures. Now, we know that ablation for atrial fibrillation has been well established for paroxysmal or episodic atrial fibrillation with good success rates. However, when patients become persistent with their atrial fibrillation, the success rates start to fall. And traditionally, our field felt that isolating the pulmonary veins is not enough for the ablation of persistent atrial fibrillation. And in fact, at the time, maybe 5 or 6 years ago, guidelines actually recommended to do further ablation, like adding linear ablations, kind of like the Mays procedure, which was originally described in the surgical literature, or adding ablation of very specific electrical signals, which we call fractionated electrograms. And we thought that by adding this additional ablation, in addition to pulmonary vein isolation or PVI, that we would improve the success rates for our patients. Having said that, myself and a few colleagues tried to evaluate that hypothesis in what we call the STAR AF2 trial, where we looked and compared 3 different strategies for ablation of persistent atrial fibrillation. And much to our surprise, we found out that adding more ablation did not necessarily improve the outcome of the patients, and that pulmonary vein isolation alone seemed to be enough. Having said that, if you look at those Kaplan-Meier curves, you'll see that our 18-month success rates, as measured by time to first recurrence of atrial fibrillation, are not all that good. You'll see that our success rates are in the range of about 50%. Having said that, that's measured as a time to first recurrence of AFib lasting 30 seconds or more. And most of us would agree that if someone starts off with persistent AFib, and then we convert them to a scenario where they're only left with maybe 31 or 32 seconds of AFib, that would be a success. And so measuring total AF burden is probably a better way of establishing the effectiveness of our procedures. And you can see here that even though I showed only a 50% success rate in terms of time to first recurrence, almost 90% of the patients had their AF burden reduced from 100%, because remember, these were persistent AF patients, to less than 10%. So sometimes the Kaplan-Meier curves don't give you a good sense of how effective the ablation procedures are. Now, a lot of people's reaction to STAR AF2, in addition to surprise, was criticism. They said, well, you know what, the trial was performed a long time ago. We didn't have all our fancy toys like we do now. For example, now we have ablation catheters which can actually measure the amount of contact force we make with the tissue. And it's believed that this may improve our ability to create lesions and therefore durable pulmonary vein isolation. And indeed, when we repeated a smaller trial very similar to STAR AF2 using some of these newer technologies, we were able to demonstrate that the 1 procedure success rate had now improved to about 70%, again, using only the minimalist PVI approach. Having said that, what's very interesting is that when patients fail a first procedure, we will sometimes bring them back to perform a second procedure. And in this trial, again, we were only doing the minimalist pulmonary vein isolation approach. And we found that if we brought the patient back and simply touched up their veins and filled in whatever gaps may have been left from the first procedure, the success rate overall didn't change very much. The one procedure success rate was about 70%, and the two procedure success rate was only about 75%. So it seems like you can do as much ablation around the pulmonary veins as you like, but we are far from getting to that 100% number. And so even though STAR-AF2 suggested that no further ablation should be performed, a search for new targets has begun. And since STAR-AF2, there have been a number of new targets which have been investigated to see if we can actually improve the outcomes for our patients. And I'm just going to briefly go through them with you. I'm not going to go into too much detail because I don't want to bore you with that, but there are some nice pictures that I can show you. So one of the things that we have learned to do in the last 5 or 6 years is that we have been able to develop technologies where we can actually map atrial fibrillation. And in the process of mapping atrial fibrillation, sometimes with these very fancy catheters, like the picture that I'm showing you right here, we've actually been able to determine that there are some repetitive processes happening in the atrium while atrial fibrillation is going on. And some of these processes look like focal triggers. Some of them look like rotational triggers, which we sometimes call rotors. And some of them look like small isthmuses of slow conduction, which we call glias. And so these are just some pictures to illustrate that even in a chaotic rhythm like atrial fibrillation, there may be some repetitive patterns that are important for maintaining the arrhythmia. So a number of technologies and researchers said, well, why don't we compare PVI plus these rotor type ablations, like the ones that I showed you in the previous slide, to traditional PVI and other types of interventions that we normally do. And one of the largest trials was called the REAFFIRM trial. This trial has yet to be published in paper format, but was presented at our Heart Rhythm late-breaking trials in 2019. And what it showed was a little bit disappointing, that addition of this so-called rotor ablation really didn't seem to make a difference to our traditional strategies. Having said that, when we look at the subsets of the trial, what we actually find out is that in the patients who actually received PVI plus rotor ablation, they seemed to do the best, because there were other patients where they may have been randomized to receive PVI plus rotor, but either they didn't have rotors at the time of the ablation, or other things happened during the procedure which prevented them from actually getting their rotor ablation. And now we can have very sophisticated technologies for finding these focal or rotational activations. So this kind of almost looks like a galaxy or something like that, where this is like the sun and you see these vectors of flow happening during atrial fibrillation. And this thing that looks like a black hole is one of those rotors that I was talking about. And what this technology is capable of showing is which ones of these phenomena are actually active, like in this case, the sun or the focus, and which one of these are simply passive phenomena, in which case this black hole is really just more of a passive phenomenon. And maybe we can be smarter about which of these phenomena we're actually going to ablate. Another approach that has come up is to look at the disease of, oops, I think I froze there for a second. Okay, so what we're looking at is to look at the disease of the atrium, try and identify scarred areas within the atrium, and then look to ablate those scarred areas, hoping that that may help to solve the problem of atrial fibrillation. Now, there are different ways to define scar in the atrium. We can either define it by voltage, which is a traditional mapping method that we use inside the heart, or we can use MRI imaging to look at scar burden in the left atrium. The trick here, though, is that the atrial tissue is very thin, and so it can be very difficult to detect this scar. So this hypothesis was actually tried out in the so-called DCAF study. And the DCAF study compared an approach where patients with persistent atrial fibrillation either received pulmonary vein isolation alone, or they received pulmonary vein isolation in addition to ablation of scar areas defined by cardiac MRI. And this trial was presented just a very short time ago at the European Society of Cardiology during their late-breaking trials. Now, again, everyone expected that defining scar would be able to help us target key areas, improve outcome. Unfortunately, yet again, we've shown that additional ablation, this time in the form of scar ablation, still doesn't seem to have any significant value over pulmonary vein isolation alone. Are you getting a bit of a theme here that PVI seems to do as best as we can, and every time we try and add something on, we're not getting the success that we imagined? Finally, there's a technique where we can isolate the posterior wall, and this is borrowed straight from the Cox-Maze surgical procedures. So those of you who are familiar with Cox-Maze surgical procedures know that way back in the 60s, Dr. Cox invented a procedure where you could slice the atrium into a number of different pieces and sew them back together in order to stop atrial fibrillation. And one of the cuts that he did was to isolate the posterior wall. So we've tried to replicate that with our ablation procedures. Certainly in a meta-analysis of smaller studies, there seems to be a benefit of this approach. Having said that, we don't have any large-scale trials to show this. Now, there was one small trial that was recently completed, which compared a hybrid surgical and catheter approach, the so-called convergent approach, compared to just the catheter approach alone. And the big difference between these strategies is that in the hybrid approach, they isolated the posterior wall. And you can see that that did seem to provide some benefit. But at the end of the day, if we're going to start performing more ablation in patients' hearts, we have to be somewhat skeptical about whether that's actually going to provide further benefit for the patient. And so we're actually starting a follow-up trial to STAR-AF2, which unoriginally is called STAR-AF3. And we're comparing three strategies of AF ablation: the traditional, plain, ordinary pulmonary vein isolation approach versus PVI plus posterior wall isolation, like I showed you, versus PVI plus elimination of rotors and other activities, again, like I previously showed you. We're hoping to enroll 600 patients in this trial. We already have our first patients enrolled, and we're in the process of activating 35 to 40 centers around the world. Now, I'm going to skip topics a little bit and talk a little bit about the need for oral anticoagulation after a successful AF ablation. So a lot of patients who come to get their AF ablated say, well, listen, if you can eliminate the AF, can I stop taking these blood thinners? And the answer to that is we don't know. And in fact, the most recent guidelines from the International Consensus Statement on Catheter Ablation of Atrial Fibrillation say that if a patient has risk factors for stroke, in other words, if they have a CHAD score of greater than 1 or a CHADS VAS score of greater than 2, then even if you think you have eliminated all the atrial fibrillation, they recommend continuing the oral anticoagulation. Now you can see on the right-hand side here that this is not based on any evidence whatsoever. So even though it's a class 1 recommendation, the grade of evidence is class C-EO, and EO stands for expert opinion. So there are no trials to actually tell us whether we can stop oral anticoagulation or not. So if we think about the arguments for and against continuing oral anticoagulation, the old ASSERT trial done by my colleague Jeff Healy in 2012 gives us an indication of why we may not be able to stop oral anticoagulation, because he showed that as little as 6 minutes of atrial fibrillation could increase the risk of stroke by 2.5 times. So if that's the case, and we know that even though our ablation procedures are good, they're not perfect, then even 6 minutes may be enough to increase the risk of stroke. Having said that, it's kind of interesting because they did a sub-study of this trial where they compared different durations of atrial fibrillation, 6 minutes to 6 hours, 6 hours to 24 hours, and greater than 24 hours. And so even though the original trial suggested that 6 minutes was a critical number, when they actually looked at all of the different strata, they found that only patients with more than 24 hours of atrial fibrillation actually had increased stroke risk, and all the other shorter durations of atrial fibrillation did not.
Right, Graham.
Furthermore, if we look at the Circadose trial, this was done by my colleague Jason Andrade in British Columbia, you can see again that the Kaplan-Meier curves, which represent a time to recurrence of atrial fibrillation greater than 30 seconds, doesn't look that good. And so you might look at these 50% success rates and say, Atul, your procedures aren't very good. And if they're not very good, we shouldn't be stopping the oral anticoagulation because our patients are going to continue to have atrial fibrillation. Having said that, again, time to first recurrence of AF may not be the best way to look at this. And what made the Circadose trial unique is that all of the patients in the trial were implanted with a continuous AF monitor, which can monitor AF 24 hours a day, 7 days a week. And what they found was that ablation, even though measured by Kaplan-Meier analysis, was only 50% successful, they showed that the ablation procedures actually reduced the AF burden by more than 99%. So even if a patient continues to have atrial fibrillation, it's usually a very, very small amount and maybe small enough that we no longer need to worry about the risk of stroke. Now, some people will show you data like this, where this red line represents a stroke, and these gray bars represent the time during which the patient was monitored. And the black in the gray bars represents the time that the patient was in atrial fibrillation. So in some patients, for example, this one, you see that atrial fibrillation clearly is related to the stroke. But then there are other patients who hardly have any atrial fibrillation, and yet they still have a stroke. And so this kind of data would suggest that we need to continue the oral anticoagulation. Having said that, the underlying mechanism of these strokes is not known. Most are probably due to non-cardioembolic events, and only 20 to 30% of them may be actually due to cardioembolism or atrial fibrillation. So we don't know whether continuing oral anticoagulation would actually help or not help. So we're actually testing this hypothesis. We started a trial a few years ago now called the OCEAN trial, which I'm doing with my colleague David Burney at the University of Ottawa Heart Institute. And the objective of this trial is really to compare a strategy of ongoing oral anticoagulation versus aspirin alone for reducing the risk of stroke, systemic embolism, or silent cerebral infarction on MRI in patients who have undergone a successful AF ablation with a CHAD score of 1 or more. So what we're doing is we're taking patients who have had 1 or more successful ablation procedures at least 1 year ago. So it may have been 5 years ago, 10 years ago, 4 years ago, or minimum 1 year ago. We're then doing additional screening on that patient to confirm that they are in fact free of atrial fibrillation. And then we're subjecting them to a baseline cerebral MRI. We then randomize the patient to either aspirin or rivaroxaban. We follow them for 3 years. We repeat another cerebral MRI, and we are projecting a sample size of about 1,600 patients in order to see whether one strategy, aspirin or rivaroxaban, is better than the other. To date, I'm proud to say that we have more than 1,200 patients enrolled, so we still have a little bit of work to do, but I want to thank all of the participating centers and investigators, and I think this data will be very important for helping to guide future care of these ablation patients. Finally, I'm going to end off with a little bit of a sneak peek into newer ablation technologies. Now, you'll remember when I showed you that picture earlier of how we do AF ablation, I told you that AF ablation today is performed either by burning atrial tissue with radiofrequency energy or freezing atrial tissue with cryoablation energy. In both cases, we are using thermal energy to ablate cardiac tissue. Now, in and of itself, that's not a problem. The problem is that very close to the heart are a number of other key collateral structures that could potentially get damaged by either burning or freezing in the heart. For example, the phrenic nerve runs very close to the heart, and if we damage the phrenic nerve, we're going to cause phrenic palsy. The esophagus is located right behind the left atrium of the heart and often is separated from the heart by only 2 to 4 millimeters. So you can imagine that if you are injuring the heart either by freezing it or burning it, you could potentially injure the esophagus. And in very, very rare circumstances, that could even lead to a fistula between the atrium and the esophagus. And needless to say, that's a very, very deadly event. Fortunately, these complications don't happen very often, less than 1% of the time. But wouldn't it be nice if we could eliminate the possibility of these complications completely? And so that is where some of the newer ablation technologies are heading. And probably the most exciting of these technologies is something called pulse field ablation, or in a more general scientific way, for those of you who work in basic science labs or who have done basic science work, you may be familiar with the term electroporation. So what is electroporation or pulse field ablation? Well, instead of applying a thermal energy like heat or freezing to the tissue, what we do is we expose the tissue to an electrical field. And what this does is this actually opens up the pores of the cells in the tissue. Now, in basic science labs, we take advantage of this because when we open up the pores of the cell, we can actually insert genetic material into the cell. And if we do what's called reversible electroporation, we temporarily open those pores, we insert the genetic material, and then we let the pores close, and now the cells have become transfected with genetic material. That's what we do in our genetic labs each and every day. But what we're looking for is irreversible electroporation, where we want those pores to stay open. As a result, all the fluids and critical electrolytes that are in the cell leak out, and eventually that leads to programmed cell death or apoptosis. And this is in fact what we do to a lot of our food products, interestingly enough. Irreversible electroporation, for example, is used to treat broccoli, to get rid of pests on broccoli. It's used to pasteurize milk. It's even used to make McDonald's French fries more flexible so they don't break in the freezer. But in this case, we're using it for the purposes of cardiac ablation. Now, if we dial up the electrical field too much, then we get back into thermal necrosis or overheating of the tissue, in which case we're not doing any better than radiofrequency. So we really want to hit that sweet spot of what we call irreversible electroporation. And why does irreversible electroporation have an advantage over heat or freezing? It's mainly because of tissue selectivity. So as it turns out, myocardial tissue is some of the most sensitive tissue in the human body to electrical fields. It's very easily destroyed by electroporation. In contrast, vascular smooth muscle, which is what's located in our esophagus, or nerve tissue, which is the phrenic nerve, are relatively resistant to electrical fields and therefore do not get damaged. So isn't that really cool that we could selectively target myocardial cells without causing any collateral damage to other organs? Now, it may just not be about tissue selectivity. It may also have to do with tissue regeneration. And in the case of the esophagus, it is possible to damage the esophagus with high doses of electroporation. Having said that, because electroporation causes programmed cell death, it doesn't disrupt the extracellular matrix of the tissue. And so for a tissue like the esophagus, which can regenerate, that allows progenitor cells to come in, repopulate the extracellular matrix, and within 1 or 2 weeks, the esophagus can repair itself. And so that's another reason why the esophagus may be more resistant to electroporation compared to cardiac tissue, which is a terminal cell, which means it's not able to regenerate. It's not able to reproduce itself. It's a terminal cell. Once it dies, it's dead. Another factor may be tissue plane. So we can deliver a high electrical field within the left atrium, but as I mentioned, the esophagus is located just behind the left atrium and is usually separated by a fat layer that is only 2 to 4 millimeters in depth. Having said that, that's enough to deflect a lot of the electrical field so that by the time the field reaches the esophagus, it's a relatively low electrical exposure. So there are many, many different ways that we can do electroporation and that we can deliver electroporation, and I'm not going to bore you with all of the details, but one of the reasons why this has only come up now is because we needed the technology to be able to deliver these very fast, brief, pulsatile electrical fields to the tissue. And often we're delivering tens of pulses within a fraction of a second, each of these pulses having a pulse width that is less than 10 microseconds. So you need computing technology, you need pulsatile delivery technology, you need microchips, you need all this kind of stuff, which has really only been able to be developed more recently. The other big advantage to pulse field ablation is that it's fast. And I'm going to play this video a second time. But what you're going to see in this video is you're going to see here are the signals that we record from inside the heart, in this case around the pulmonary vein. And we're trying to eliminate these signals. With freezing or burning technology, that often takes a long time. Eliminating all of these signals can take many, many minutes to do. But with pulse field technology, which is delivered in a fraction of a second, the signals go away literally right away. So I'm just going to show you, these are the signals. You're going to see a little interruption in the screen right there. That was the pulse field ablation delivered in a fraction of a second. And look at that, all of the signals are gone. So this has the ability to turn our 2, 3, 4-hour ablation procedures into 1-hour procedures that are more safe. Because as I pointed out, and this is some animal preclinical work that we did with pulse field ablation, here is an example of a phrenic nerve where we delivered radiofrequency energy, and you can see that we destroyed the phrenic nerve completely. On the other hand, when we delivered electrical field ablation, the phrenic nerve remains completely intact, and yet the cardiac tissue that is beneath the phrenic nerve is completely ablated. Similarly, we designed an experiment in which we took an animal model and we delivered pulse field or radiofrequency energy from the aorta and directed it to the esophagus to see if we could create esophageal damage or esophageal fistulas. And indeed, with the heating energy, where we were able to create horrible lesions within the esophagus, horrible damage, in one case a fistula. And on the other hand, when we delivered pulse field ablation, you can see here that the esophagus is completely intact without any damage whatsoever. Furthermore, sometimes if we deliver our energy too deep into the pulmonary veins, we can cause pulmonary vein stenosis, which can cause permanent shortness of breath in patients. This doesn't happen very often anymore, but theoretically could happen. But what's so interesting is that, again, when we use pulse field ablation, for whatever reason, we're unable to create pulmonary vein stenosis. So this is radiofrequency or heating energy, and we see a reduction in the size or the lumen of the pulmonary vein, whereas with pulse field ablation, we see no such stenosis occurring. This is the first human experience of pulse field ablation that using a system designed by Medtronic. I had the pleasure of leading this trial as well as the pivotal trial, which is ongoing. I need to thank all of the members of the steering committee and investigators who helped to contribute to this. This is just preliminary data on the first 14 patients that we presented at the Heart Rhythm Society a year or two ago. We are now well beyond 400 patients in terms of enrollment, and so we're going to get much more definitive results. But what was so interesting is that pulse field ablation was able to successfully isolate the pulmonary veins in all of our patients, 100% success acutely. Again, the reduction in electrograms is really, really fast. So here are the pulmonary vein signals that we're trying to eliminate. We deliver one pulse field and boom, they're gone. So in terms of the efficiency of the procedure, we can see here that the dwell time in the left atrium was only 90 minutes. And that included a study mandated 20-minute waiting period. So you can see that if we didn't wait those extra 20 minutes, we probably could have done the procedure in just over an hour. The skin-to-skin procedure time includes removal of the sheets and the recovery of the patient. So it's really not a very good measure of the actual procedure time. We can see that in some of the patients, we use conscious sedation. In other patients, we use general anesthesia. And overall, in terms of the incidence of complications, we saw no evidence of esophageal injury. In fact, we actually measured the esophageal temperature during the ablation using a luminal temperature probe, and we saw absolutely no change in the esophageal temperature, which is really quite incredible, and none of the patients developed any phrenic nerve injury. So I'm going to wrap up here in order to give time for questions, but basically what I've shown you today is that the optimal method for ablation of persistent atrial fibrillation is still a work in progress. Stopping oral anticoagulation after a successful ablation procedure may be a possibility, but we need to finish the OCEAN trial to determine that. And finally, newer technologies for ablation promise more safety, efficiency, and possibly even efficacy. And we'll find out from some of the trials that we're doing in the very near future. All right. Thank you very much for your attention, and I'd be happy to answer any questions.
Thank you very much. This is Dr. Verma, as I mentioned to everyone, our future chief of cardiology, and very, very excited, Atul. Thank you for that wonderful presentation, really. And congratulations on all the work that you have done, you and your team have done to advance this very complicated field. And it's wonderful to see how this field of atrial fibrillation is evolving. I'm going to ask people to enter questions in the chat. And as people are entering their questions, I have a quick question for you, just a big picture type of question. We know the population is aging. We know there will be more atrial fibrillation. As I listen to this lecture, and I think, the technology that is used to treat these patients is obviously going to be, time consuming, costly. So what percentage of patients with AFib are silent versus those who are symptomatic to the point where we need to do ablations? And do we have concerns sort of as the population ages about what's going to happen with this disease?
Yeah, it's a very good question. There's no doubt that the incidence of atrial fibrillation has been climbing, year after year as the population ages. I think it's very important to recognize that not everybody with atrial fibrillation needs to be ablated. At the present time, we've looked at this actually within Canada and other country jurisdictions. We're probably only ablating a very small fraction, maybe about 5% of all the patients with atrial fibrillation are we treating with ablation therapy. In the US, that number may be closer to 10% possibly, but even there, the vast majority of AFib patients are not being ablated. And there are a number of reasons for that. Either the AFib is silent, as you mentioned, which it is silent in many patients. Other patients may simply be too old to undergo a procedure like this. They may have other comorbidities like fragile heart failure, etc. So while there are certainly some heart failure patients who would benefit from this, it's certainly not a procedure for everyone. But the reality is that the incidence of AF ablation is going to go up, and we need to make sure it's cost effective. And a number of analyses have been done suggesting that the use of resources like emergency room visits, cardioversions, drugs, etc., seems to be far in excess in terms of cost than doing an ablation procedure and eliminating the AFib.
Fantastic. So I'm just looking at the chat. Dr. Tahan is asking, in the OCEAN trial, what is the reason to compare viroxaban to aspirin instead of placebo? Knowing that the risk of aspirin and DOAC, sorry, I'll let you, knowing that aspirin, I guess, is not recommended in AFib.
Yeah, that's a very great question, and one that comes up often in the OCEAN trial. So aspirin certainly has been tossed out of the guidelines for patients who are low CHADS risk. So if they're CHADS 0 or if they're CHADS VASC 1, I agree, aspirin should not be used because A, it doesn't provide a ton of benefit in those low risk patients, but B, it may increase the risk of bleeding. Having said that, when we look at patients who have established CHADS or CHADS-VASc risk factors, which all of our OCEAN patients do, So they all, by definition, have a CHAD score of greater than 1 or a CHADS-VAS score of greater than 2. Then we don't really know what the best comparator is. Is it placebo? Well, we actually don't have a lot of placebo trials in those higher risk patients, except for the very, very old SPAF trials, which looked at Coumadin. And in those older SPAF trials, aspirin did show some benefit in the higher risk subgroup as opposed to the lower risk subgroup. So I think it's very important to understand that when the Europeans, Canadians, and Americans say aspirin should not be used in AFib, they're specifically referring to the low-risk patients who would not otherwise be candidates for oral anticoagulation.
Fantastic. Dr. Desculpa wants to know, how feasible would it be to combine left atrial occlusion and ablation routinely?
You know, in terms of the procedure, it's very easy. I mean, you're in the left atrium anyway. So if we're doing an ablation, we just simply have to switch over our catheters and we can, in addition, occlude the left atrial appendage. The key word there is routinely. Do we need to do that routinely? Because obviously the ablation is an expensive procedure. The left atrial appendage occlusion is actually even a more expensive procedure than the ablation is. And so the question is, do all patients undergoing ablation need to have their appendage occluded? I would say probably not. I mean, the whole point of doing the OCEAN trial is to see whether, if by eliminating the AFib, we can also eliminate the need for oral anticoagulation. And if that turns out to be the case, then there is no need for putting in a left atrial appendage occlusion device. Furthermore, occlusion devices are really only indicated at the present time for patients with refractory severe bleeding who cannot tolerate oral anticoagulation. And fortunately, most of our ablation patients are sufficiently well that not a lot of them are having refractory, fatal, or severe bleeding on oral anticoagulation. So yes, it can be done. Does it need to be done? No.
Okay, thank you. Can ablation be precisely localized to the pulmonary vein regions in electroporation, or will a larger area of the atrium be ablated in this procedure? And what are the other challenges with electroporation?
Yeah, that's a great question. So, of course, if you're exposing anything to an electrical field, it's a field, right? So how do you control how far that field spreads? And the answer is that most of our catheters that are delivering electroporation have small electrodes that are in the range of about 2 to 3 millimeters. And so even if you deliver, let's say, 1800 volts or 2000 volts into those small electrodes, the total amount that the field spreads is only about 2 to 3 millimeters. So really, if you have your catheter in contact with the tissue or almost in contact with the tissue, you know, the field is only going to have about a 2 to 3 millimeter spread from the catheter. So it's not like you're delivering a huge jolt of electricity into the middle of the left atrium like a cardioversion. It's much more controlled than that.
And Atul, what about the recurrence rate? Failed ablation, are we able to exclude the ones who are not likely to benefit? Can you talk to us a little bit about that topic?
Yeah, so I showed a table earlier on, you know, of people who are potentially good candidates for AF ablation. I think the two major things that we look at as operators are, first of all, if they have persistent AFib, how long has it been going on for? You know, and if it's been going on continuously for more than 5 or 10 years, where they've never seen sinus rhythm for 5 or 10 years, there's a very low likelihood that we're going to be able to change it at that point. The horse is already out of the barn. Furthermore, we looked at left atrial size. So we still look at diameters rather than volumes. And if the left atrial diameter is more than 55 to 60 millimeters, again, that atrium is probably irreversibly damaged and therefore unlikely to respond to our ablation. So those are probably the two most important criteria that we look at.
Thank you. We have a question here about enrolling women in clinical trials. In OCEAN, are there enough women in the clinical trial? And a comment that sex differences has been shown in who gets ablated and in the outcomes, the difference in outcomes.
Absolutely, fully agree. So all of the early trials on ablation were overwhelmingly male dominated. 70 to 80% of the patients enrolled were male. Fortunately, we have seen a change in the last few years where now we are seeing closer to a 50-50 ratio of men to women being enrolled. And we have noticed that there are sex differences. For example, women with persistent atrial fibrillation may not respond as favorably as men to pulmonary vein isolation. We don't exactly know the rationale for that or the reason for that, but finally, for the first time, we're actually getting data which can inform that area of research. In the OCEAN trial, I forget exactly what our most recent percentage of women in the trial are. I believe it's in the 40 to 45% range. So it is still not at parity, but certainly a lot better historically than many of the ablation trials that we've had to date.
Thank you. Stephen Grover says, great presentation. Provocative question. How much further ahead do you think we are with AFib treatment compared to the old days where we prescribed Coumadin, aspirin, or did nothing because we thought the bleeding risk was too high? So he wants to know, have DOACs and cath interventions made a real difference clinically?
Great question. I think so. I think if we look at the anticoagulation side of the story, there's no doubt that the big advantage of all the DOACs is a reduced incidence of fatal bleeding, a reduced incidence of intracerebral hemorrhage. The incidence of clinically relevant non-major bleeding or major bleeding may be exactly the same as Coumadin, but I think if we can cut down on those fatal bleeds, I think compliance generally is also better, and the ability to get more consistent anticoagulation versus INR monitoring with Coumadin. In terms of catheter ablation versus antiarrhythmic drugs, I think it's a no-brainer. A whole topic that I didn't get into is first-line ablation and all the trials comparing ablation to antiarrhythmic drugs, including amiodarone. And catheter ablation does much, much better than antiarrhythmic drugs. So I do believe that both of those things have pushed the needle forward.
Thank you. Mark Roger wants to know, he didn't see high bleeding risk. So the contraindication to anticoagulation is as a current indication for AFib ablation in your slide. Can you comment on that?
Correct. So that's a great question, Mark. So as of the time being, the guidelines still say that even if you have a successful ablation and you eliminate the atrial fibrillation and you have a CHADS score of 1 or more, you should still be on oral anticoagulation. Now, those guidelines may change after the OCEAN study. Who knows? We don't know what the results are yet. But because the guidelines still say you need to continue oral anticoagulation, a contraindication to anticoagulation is not an indication for AF ablation.
Okay, that makes sense. So just coming back, we're going to let you go in a minute or so, but just coming back to, this is a growing population, a growing volume of activity, the cost of the catheters and the labs and everything that goes with that. What about the other resources that one needs? Are you requiring transesophageal echo before everyone gets an ablation? Do you have cardiac anesthesia present in all the room? I just want to get a sense of what kind of resources do we need to make this happen?
Yeah, so traditionally we were getting transesophageal echoes on all patients undergoing ablation. Because obviously you don't want to be in the left atrium if there's a big clot sitting there. Having said that, I think we have gotten smarter with that. We are now able to identify lower risk patients who are very unlikely to have a clot and who perhaps can forego having a preoperative TEE. In terms of anesthesia, I think anesthesia has been shown to be a benefit for these procedures. Obviously, as you're ablating, you're doing so in a beating heart and in a breathing patient. So you've already got heart motion to deal with and breathing motion to deal with as you're trying to move your catheters in the heart. And then on top of that, if the patient is moving, it can be very, very challenging. And so, having the predictability of a general anesthetic where the patient is not going to move and you're able to control the breathing and other things to a certain extent, it certainly has benefits. So I think, yes, it is, certainly resources are required for ablation. I think as we see new technologies making the procedure more efficient, we'll be able to do more in the same amount of time, which I think will overall lower costs. So I do see a positive future for what it is that we're doing.
Fantastic. So I see some comments, people thanking you for your great presentation. I think we're going to stop there because you've answered many of our questions. Congratulations. Really terrific presentation. Certainly I learned a lot and myself, and I know people have. I'm seeing the comments here. We look forward to having you with us in person. And as a member of our team, congratulations on all the work that you've done so far in this field. And thank you very much for that really terrific presentation today. So I'd like to thank everyone for attending. We had over 127 or so participants, so really an outstanding turnout today. So thanks everyone for joining us. And please remember to fill out the survey that will be sent to you immediately at the end of this presentation. Atul, thank you very much.
Really looking forward to coming to McGill. It's going to be exciting.
We look forward to having you here. Thanks again.
All right.
Bye.
Bye-bye.
Bye, everyone. Bye.